Okay, hello everybody. I think we're live. My name is Dr. Kenneth Kernen. I'm a urologist at the Michigan Institute of Urology. My specialty is urologic oncology. I help run prostate cancer research in our research department with Dr. Jason Hafron. I'm chief of urology at Troy Beaumont, also now known as Corewell. And it's really an honor to talk to you tonight about prostate cancer. I don't think prostate cancer gets nearly enough publicity, and we'll talk more about that as we go along. A few housekeeping notes. The information supplied in this webinar is for informational purposes only, does not constitute medical, legal, or any other professional advice. Healthcare-related information is provided not as a substitute for medical advice and should not be used to diagnose or treat health problems or to prescribe medical devices or any other remedies. This information may be presented in conclusory, shorthand, or summary form and is not intended to replace sound medical advice provided by your own physician or healthcare provider. We will have some time for general questions after the presentation, so please do send in some questions through the chat button in the webinar interface, and we cannot answer personal medical questions on this webinar. Maybe someday, but not today. All right, here we go. So, prostate cancer and clinical trials, everything you needed to know, but we're probably afraid to ask. This is again me. I did my Bachelor of Science at Michigan State University, go green. Did my Doctor of Medicine at Wayne State in Detroit. Urology residency was at Beaumont Hospital. And then I did my Urologic Oncology Fellowship at the Baylor College of Medicine in Houston, Texas. So again, I do all urologic cancers, adult urology only, some male sexual dysfunction, BPH, and kidney stones. My offices are at Town Center in Troy and West Bloomfield. And again, I'm chief of urology out at Troy Beaumont Hospital. Okay, what's the prostate? Besides something that torments all of us men as we get older, it's a small gland that's located below the bladder and in front of the rectum, and the urethra passes through it like a donut. It's got an abundant nerve supply around it, and that contributes to the ability to have an erection. Its job, besides to torment men as we get older, is to produce a fluid that contributes to the formation of semen. Size in younger men is probably walnut size, and then it just starts growing as we get older and becomes larger and larger. And in some men, it can get to be apricot size, lemon size, grapefruit size. So it just keeps growing in some men. Stats. This is really important. It's actually the second most common prostate cancer in men. It's the second leading cause of cancer-related deaths in men. And then the average age of diagnosis is about 67 years old. But we've actually diagnosed men as young as in their late 30s, and early detection dramatically increases the odds of survival, right? So there's approximately maybe 250,000 new cases in the United States every year, and about 1 out of 8 men will be diagnosed with prostate cancer in their lifetime. The problem is nobody ever really talks about it, right? So October is Breast Cancer Awareness Month. It's great. You watch NFL football, the NFL guys are wearing pink, they got pink gloves and pink towels. If you fly on an airplane, they've got pink cocktail napkins. If you flew 1 month before in September, which is allegedly Prostate Cancer Awareness Month, nobody talks about it, right? The NFL is not wearing blue. They're not doing anything for prostate cancer. And really almost the same number of men die of prostate cancer that women die of breast cancer. But we don't really get any publicity. Part of that's our own fault. A lot of our men that we diagnose with prostate cancer don't like talking about it. Where historically, if a woman's diagnosed with breast cancer, they'll go tell 10 or 20 or 50 or 100 women about it to get that message out there. So guys, we're not really talking about it. A lot of guys, when they get diagnosed, are almost embarrassed about it. So again, it's really up to all of us as prostate cancer doctors to get out there and really spread that message. And that's why something like this is so important, because hopefully at the end of this discussion tonight, you'll know what's your prostate, what's your PSA, why is all that important, and then how to screen and ultimately get treated. So what's cancer, right? So cancer is any cells growing out of control. Prostate adenocarcinoma, that's kind of the fancy name for the generic form of prostate cancer. It originates in the prostate gland itself, and then we can find that by doing a prostate biopsy. If you get diagnosed late, prostate cancer can actually spread and travel to other parts of your body. What's the most common symptom? we probably all have the most common symptom, which is zero, right? The most common symptom that I see in men with prostate cancer is none. Even the guys that walk in, and sometimes we have a guy who'll walk in, they've been to their primary care doc for 5, 7, 10 years. That primary care doc doesn't believe in prostate cancer screening, which is insanity. So they come to see us and they say, hey, maybe I should get a PSA. And I heard about this prostate cancer thing, and my dad had prostate cancer, and I do their PSA, and their PSA is 1,000, right? Even most of those guys don't have symptoms. Now, some symptoms can be difficulty in starting urination, a weak stream, urinary interruption, getting up at night, pain or burning, blood in the urine or semen, pain in your back, hips, or pelvis that doesn't go away, and painful ejaculation. But most patients, again, have zero symptoms of prostate cancer. And probably one of the first things that people say once I tell them they have prostate cancer is they say, how is that possible? Because I don't have any symptoms. So just because you don't have symptoms doesn't mean you don't have prostate cancer. Risk factors. So super rare under 40, increases dramatically after 50 years old, definitely more common in Black men, less common in Asian Americans, Asian Pacific Islanders, and American Indians and Alaskan Native men. Family history, super important, right? So if you have a father or brother with prostate cancer, it essentially doubles your risk of developing prostate cancer. So that's why we ask these questions like, hey, did your dad have prostate cancer, or did your uncles have prostate cancer? Do you have a brother? And now we know through some genetic testing, if there's breast cancer that's running in your family, or pancreatic cancer that's running in your family, or potentially colon cancer that's running in your family, you might be at a higher risk for prostate cancer. So these questions about family history are really, really important. Obesity increases your risk of prostate cancer. Diet, right? Everybody wants to say, hey, what's the best thing to prevent prostate cancer? And, I tell people, well, polyphenols are supposed to be good to help decrease that. So that's things like lycopenes and tomatoes and bright colored fruit. And then things like red wine, right? Red wine has polyphenols. So that's my excuse for red wine. So I can't really tell you that there's one thing that's going to be from a diet standpoint that's good or bad, but essentially anything that's heart healthy is going to ultimately be prostate cancer healthy. So screening tools, DRE, which is digital rectal exam. And by digital, we don't mean technology digital. We mean digital like the finger digital. We talk about giving it the urology handshake. So we feel for any abnormal changes. It can't feel most prostate cancers, and most are actually too small to be felt. But I will say it's still an important thing. And we see a lot of patients, and we probably still diagnose 10 or 15 prostate cancers a year just with a physical exam. And interestingly enough, a lot of those men's PSAs did not change. So if I had to pick one thing for you to do out there as a man, it would be to get your PSA every year. But it is important to still probably get a prostate exam. So the blood test, PSA, prostate-specific antigen, also known as patient-stimulating anxiety, right? So when people have PSAs and they go up, everybody gets nervous about it. So it's a protein made by both cancerous and non-cancerous prostate cells, and that gets excreted into the bloodstream. Men with prostate cancer usually have really high PSAs. What's a high level? There's no real normal. We know that if you're in the 40 to 50 range, your PSA probably should be under 2.5. 50 to 60, probably under 4. 60 to 70, probably under 5. 60 or 70 to 80, probably under 7. So as we get older, that prostate grows, it makes more PSA. The most important thing I can tell you to remember is it's not necessarily what the number is, it's the change in the number. So you should know what your number is. And if it goes up by more than 1 point in 1 year, that's a red flag. So if that happens and your PSA this year is 1 and next year it's 2, your primary care doc may say, well, that's fine. It's still under what's normal. But you're going to say, I heard this guy, Dr. Kernen, he said if it goes up by more than 1 point in 1 year, it's a potential red flag. That's the takeaway message for tonight. More than 1 point in 1 year is a problem. So that's probably the thing that would save you most, because again, it's not necessarily the absolute number. We have guys who have PSAs that are 20, they don't have prostate cancer. We have guys that have PSAs that have 2 and they have bad prostate cancer. So that change in PSA or PSA velocity is an important trigger. All right, so how do we diagnose prostate cancer? So you come to see me, your PSA is high. I repeat it just to make sure it wasn't a lab error. So now it's still up by more than 1 point in 1 year. We're going to probably do a prostate biopsy, which basically we can either do with you being asleep, like some light sedation, like a colonoscopy, or in the office with a little bit of local. And basically a probe goes into the rectum. We sample the prostate. We take normally about 12 samples. If that comes back positive, meaning there is prostate cancer, we have a pathologist that reviews that, and they assign an aggressiveness to that prostate cancer. And it goes from anywhere from a 1 to a 5. So if you look at the right side of the screen, that kind of teal color is low-grade prostate cancer, and it still looks like normal cells. As you go down to a Gleason 2 and a 3 and a 4 and a 5, they start looking like really abnormal cells. So the more abnormal the cell looks like, the higher grade it is. And so Dr. Gleason, who is a famous pathologist, said, hey, if we see some prostate cancer, we're gonna add the 2 most common grades together. So like the average patient has a Gleason 3+3 or 3+4 or 4+3. Nobody's ever a Gleason 5 or lower. They just don't exist. Unfortunately, we see some patients with a Gleason 9 or 10. Those are really high-risk cancers. Other risk factors, the number of cores positive for cancer are important. So if we do 12 cores and you have a small percentage of 1 core and it's a low grade, we may not do anything. But if you have 12 out of 12 cores and it's a higher grade, you're definitively going to need some treatment. So we look at the number of cores and we look at the percentage of the cancer in each core. Most of our men, when they're screened properly, are diagnosed with low-grade prostate cancer, which is critical. If you get diagnosed with localized prostate cancer, you have 100% 5-year survival, 100%. So why wouldn't you get screened? If you get diagnosed with metastatic prostate cancer, meaning the prostate cancer is already spread, that number dramatically plummets to like 40%, despite all this new great stuff that's out there. So again, take-home message number 1, get your PSA, know that it shouldn't go up by more than once a year. That's really important. Take-home message 2, get screened every year, because if you get screened and we find it early, you have 100% 5-year survival. All right, so imaging. One of the cool things about prostate cancer is there's all sorts of new stuff that's happening all the time, and imaging is no different. So if you got diagnosed 2, 3, 4 years ago, we may say, hey, we're going to get a CAT scan and a bone scan to make sure that your prostate cancer hasn't spread anywhere. And it was good, but it was all that was there. Then MRIs came out and we're like, oh, this is really good. We can actually we can really see the prostate well. Sometimes we even use it as a screening test before we do the biopsy. So we can actually do a targeted biopsy based on the MRI, what that shows. The other thing is it's great at looking at the surrounding area of the prostate to make sure that no cancer has gotten out of the prostate. And it also is great to look at any lymph nodes. So that's been a better test. And we kind of use that now all the time. So then all of a sudden, probably a year and a half to 2 years ago, these PSMA, or prostate specific membrane antigen, so like little PSA molecules that are stuck on the prostate, scans have showed up, and they use radioactive tracers that attach to that membrane, and we can now see prostate cancer anywhere else in your body much better. So we really almost don't even do CT scans and bone scans anymore because PSMA PET scans are so good. So again, always something new going on, which is great. All right, staging. Staging is basically where it is. We talked about grading. Grading is the Gleason score. Higher is more aggressive, lower is better. So that's like golf, lower is better. Staging is where is it in your body? We'd like it to all be stage 1, confined to the prostate gland. And if you're getting screened on a yearly basis and you get diagnosed, you should be a stage 1. So we look at this thing called a TNM system. T is the primary tumor. How big is it? Where is it in the prostate? The penetration of the tumor, the lobes of the tumor. N stands for nodes or lymph nodes. Are there any surrounding lymph nodes around the prostate? M stands for metastasis, which means the spread of prostate cancer throughout other parts of the body. Again, we want you to be a T1, N0, M0, meaning diagnosed only with localized disease, no nodes, no metastasis. So that's kind of your risk group. You get low risk group, intermediate risk group, or high risk group. Going back to genetics, I touched on this a little bit earlier. Again, a couple years ago, we didn't really know how genetically attuned prostate cancer was. So again, now we know because of all this new research on all these gene changes related to prostate cancer, it's really helping us understand how this cancer develops. And now we actually have targeted medicine if you have some of these genetic defects that's going to make you better if you have prostate cancer. The breast cancer world's been doing this for years. You may have heard of BRCA1, BRCA2 for breast cancer. Those actually exist in prostate cancer, probably about 13 to 15 other genetic defects. So again, that's important not only as a risk factor for you to develop prostate cancer, but if you have prostate cancer, we think you have a higher aggressiveness, and we actually now have medicines to target that. So it's really helping us. So we use precision urology or precision GU. It's a testing program that's personalized care, right? So we're really customizing this to your care. We can predict your risk factor. We can determine if your children are at risk. We can help precisely guide you through treatment and decision-making. And really that ultimately helps you with peace of mind. Okay, overview. The question I get most often is, Doc, I got diagnosed with relatively low-grade prostate cancer. I'm coming to see you for a second opinion. What's the best treatment? And I go, there's no best treatment. It's like going to Chicago. So we live in Detroit, right? So how do you want to go to Chicago for the weekend, right? Do you want to drive, fly, take the train, ride the bus? You can do some other things, maybe not so good, like ride your bike, or I'm a marathon runner, run a marathon to, run to Chicago. It's not the best idea. But for the most part, there's a bunch of really, really good treatments, and they've all gotten better in the last 20 years. So again, there's no study that definitively proves that one treatment approach is better than another. So just like some people say, hey, I want to drive to Chicago, great. I tell everybody what they want to do. They want to have their prostate out, or they want to have radiation therapy. They want to have cryotherapy. That's all good. So we do really what's called shared decision making, right? So we sit there as a team and we say, these are your options. These are things that I think fit for what you're trying to accomplish. These things may not be so good. So it's really a team approach now. So we look at the side effects, short-term side effects, long-term side effects, and impacting your quality of life. The other big breakthrough is we now know that we actually don't have to treat a lot of these patients with prostate cancer. We call that active surveillance. So what does that mean? It basically means you've got super low grade, non-aggressive prostate cancer, and it's never going to grow and it's never going to spread. And this is how prostate cancer got its bad name a couple years ago, because 20 years ago, we probably overtreated a lot of guys. And because there wasn't a lot of options, we took everybody's prostate out. We now know because of science, hey, maybe we know so many new things now, and technology and treatments are better. You don't necessarily have to take everybody's prostate out. And actually, we may not have to treat you. So what do we do for active surveillance? You come see us, you've got low-grade prostate cancer, it's non-aggressive, it's confined to your prostate, we've done some genetic testing, and we say, hey, look, you probably can do nothing. So what does nothing mean? You still have to show up. So you get a prize for showing up. We see it roughly every 3 months for a year. We get some more PSAs, and at 1 year, we consider doing a repeat MRI and a repeat prostate biopsy. If you've not changed at all and everything is still the same, you probably can go on almost indefinitely. We kind of switch it over to an every 6 month, and you probably won't need a biopsy now for a long time unless something dramatically changes. One of the questions I get is, I'm never going to be younger than I am now. Why aren't you doing something now? I say, well, technology changes, right? So we have stuff today that didn't exist a couple years ago. So if you can go 3, 4, 5 years with needing no treatment, we've got all this cool stuff coming down the road. So maybe you wait 3, 4, 5 years, you live a normal quality of life, and something super cool comes down and we have a new treatment for you. Surgical therapy, still kind of it was the fundamental mainstay for prostate cancer. We love operating on people, right? It's great for patients. It's surgical therapy. It helps remove the prostate. It's intended to cure the cancer. In the old days, you'd get a big shark bite incision. People would be in the hospital for 3 to 5 days. They'd have a catheter for 2 to 3 weeks. And they did fine, but there was a higher risk of incontinence and impotence, and the recovery was just longer. Roughly 15, 18 years ago, we started doing it laparoscopically, and then the robot came out, the Da Vinci robot, And now basically all we do is take people's prostates out with the robot. Someday we won't even have to be there. We'll just sit home and it'll be great. And the robot will do the whole thing, but you still need us for right now. So basically it's now about a 2-hour procedure. You're in the hospital overnight. You have a catheter for roughly 5 to 7 days and your recovery is a lot faster. So again, traditionally urinary incontinence and erectile dysfunctions were really bad. Now it's a lot better. It's not zero, but it's significantly better because of the improved techniques. We have improved outcomes. So it's still, one of our mainstays. Again, radiation therapy, maybe 20 years ago, not so good. Again, now that's better as well. We deliver high doses of energy delivered to cure the prostate cancer and kill those cells. And we're actually able to focus that beam now just on the prostate cancer. So, we all hear these stories. Oh, my uncle had prostate cancer surgery and he had to wear a bag forever, or he leaked forever. Or my uncle had radiation therapy and they blew a hole in him. You could see right through him. None of that stuff exists anymore, right? It's all better, better, better. Sometimes we can actually minimize those effects even more by putting a little spacer between the prostate and rectum. So again, if you look at radiation surgery now, those cure rates are basically about the same. Focal therapy. It was heresy 10 years ago, right? You told somebody you're just going to treat a little bit of this one spot in prostate cancer. People would go bananas. They'd throw you out of the meetings. Now they're like, hey, we can focus it. We can target it. We can see it on MRI and we can treat just the prostate cancer that's in your prostate without treating the entire gland. So for us, it's like a lumpectomy for, women who have breast cancer. They get a lumpectomy if they diagnose it early. Now we can do that lumpectomy for prostate cancer. It's less invasive. It's done as an outpatient. Maybe you need a catheter overnight. Your risk of incontinence and impotence are almost zero. And it's super easy to do. We can use heat. We can use electricity. We can use cold therapy. Steam is coming. So that's one of the new treatments that's out there. It's primarily for lower intermediate risk prostate cancer patients. And again, it's got to be localized to basically one area, which we can now do based on biopsies and MRIs. So again, there's focal therapies that are being studied in clinical trials. We actually have one open now for vapor or steam. A lot of these have not been approved as standard treatment options, but it's coming. So here we go into something that we don't really like talking about, which is hormonal therapy, right? So we use medication to actually block testosterone. Now, in some men who are diagnosed early, but they have a big prostate, we'll use hormonal therapy just temporarily to shrink that prostate down, treat them, and then they're off therapy. So they may get 3 months of therapy, they may get 6 months of therapy. And that shrinks their prostate down. Some of the side effects are hot flashes, right? The guys don't like hot flashes. When I tell that to the men, if their spouse is sitting there, sometimes they're not so sympathetic because a lot of them already had hot flashes. But we use prostate cancer in men who have metastatic disease or disease that spread, or men with high risk of spreading, to basically deny those prostate cancer cells testosterone, and that starves those cancer cells of their fuel source. It's not exactly a cure, but it definitely stuns them and slows that growth. And if you use it in combination with radiation therapy and sometimes cryotherapy, it can become synergistic. So 2 + 2 = 8, right? If you use them both together, you get a better result. Again, side effects. Hot flashes is one that bums people out a little bit. They get that, they don't feel good. Lack of sex drive can do it. Erectile dysfunction, they can get some weight gain, loss of muscle mass. Again, hot flashes, you can get some bone loss and you can get some fatigue. So again, it's out there. It's still our mainstay though. If you show up and you have a PSA of 1,000 and you have widespread disease, we're putting you on hormonal therapy first line, in combination with other things, right? So again, if we were giving this talk 12 years ago, I would say, well, if you had prostate cancer that spread, we're going to give you some hormonal therapy and then we're going to pray. Now we have all this awesome stuff that's out there. We have immunotherapy. It boosts the body's own immune system to fight cancer cells. We have targeted therapy drugs. These are now available through clinical trials. We have chemotherapy, although we use traditional chemotherapy less than what we used to because we have all these other things. Radium-223 is a radiopharmaceutical. It delivers radiation to tumors that are prostate cancer tumors that are found in the bone. Lutetium or Pluvicto, again, delivers radiation therapy to the cells itself. So one of my favorite quotes is from St. Paul to the Romans, which is "Spe salvi factus sumus," which is "in hope we were saved." So we get these guys who come in and they have disease that's widespread and their PSA is 1,000 and someone told them they're going to die, and they come see us and they're like, well, you might die eventually, but you're not going to die for a long time because we have all this great stuff. And if we can get you living 5, 7, 10 years down the road, every 6 months that you live, there's something new that's going to come out there. And we don't have that magic cure yet, like we did for testicular cancer. So if you had testicular cancer in 1978 and it was spread, you probably were going to die. If you could have hung out till December of 1978 when cisplatin got released, you had almost a 97% cure rate. So it's out there for our men with advanced prostate cancer. We just got to get them longer and longer and longer to live. And we're doing this now with all this combination therapy. So it really provides hope to these men and their families. So it's a really great opportunity. It's a really great time for us as the clinicians to be involved in advanced prostate cancer. To Steve out there, I'm just kind of scrolling through the questions. Yes, Steve, I was referring to HIFU as well as one of those treatments for focal prostate cancer, which is high intensity focused ultrasound. Supportive care. I think it's really important. Managing that physical, emotional, and social aspects of prostate cancer. Again, a lot of our guys get diagnosed with prostate cancer and they're like, do I have to tell anyone? I'm like, yes. Do you have sons? You have to tell them. Do you have brothers? You have to tell them. Do you have anybody that you care about in your life? Tell them too, because they should go get screened. It's like a scarlet pea, right? They just don't want to talk about it. So we really help manage the physical, emotional, and social effects of prostate cancer. Talk to your clinician about goals of treatment recommendations and possible side effects. People always say, well, okay, I got diagnosed with bad prostate cancer. What do I do? I'm like, you got to take care of yourself, right? And again, I don't expect everyone to be a marathon runner like me, but you got to take some responsibility. You got to stop smoking. You got to start moving. You got to start losing weight. You have to start exercising. And I know it can be overwhelming, but you can work with us and we'll help you do that, because that's all going to make you have less side effects for all these disease treatments that you're going to get. All these these combination therapies going to give you some side effects. You got to take control of your life and you got to fight it, right? You got to fight that. So how do you fight it? You exercise, you stop smoking, you start eating right. And that's going to make you feel better. And it's going to give you some control in your own life. So again, I think it's super critical that you take some responsibility and you've got to get better and get healthier. All right, clinical trials. We've been involved in clinical trials at MIU for a really, 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 really long time. Dr. DiLoretto, one of the original partners of MIU, started it years ago. We inherited it. We moved it over to Troy. I took it over for a while. Dr. Hafron helps us now. He's helping to run it. And Danielle, it really is our head of research. We work for Danielle. And she's amazing and has put together this great program of clinical trials. We're a little bit heavily focused in oncology because Dr. Hafron and I love doing oncology. So clinical trials, why are they done? They're done for new treatments, right? If there's a new drug out there or a combination, we're trying to figure out if that works. And with our relationships to people across the country and in pharma, we get some of these clinical trials before any of the other places around the country get them. It really helps for symptoms and side effects. It helps to know what happens for late effects. It also helps to prevent and find cancer. So we do a lot of these clinical trials that are looking at urine and blood to help diagnose prostate cancer. So at MIU, we do a ton of these clinical trials. You can always go to clinicaltrials.gov and you'll be able to find those as well. So clinical trials are really important. We look at it as a blessing for our patients because we can give you things that aren't readily available anywhere else. So phases of clinical trials, right? This is kind of important. Phase 1 are really experimental. It's really in a small group of people for the first time. Basically, it's like, is this drug safe? Is it going to kill somebody? It's normally in people who are really sick. Phase 2 are still more experimental. They get to a larger group. Phase 3, again, expands that group. Doctors start to confirm the effectiveness, starting to monitor side effects. And then phase 4 trials are basically after it's approved by the FDA. And now we need more information on that treatment of drugs, risk, benefits, and best uses. So again, it's really important. You don't really want to do this if it's not an FDA approved clinical trial. So that's really important. And again, you can go to clinicaltrials.gov and see a list of a lot of those trials. Are clinical trials safe? So people are always like, oh, is this safe? Our clinical trials always follow strict guidelines. It protects participants, and all clinical research involves some risk, right? Anything involves risk. People always say, doctor, is it possible that this could happen? Yes, it is possible. Anything is possible. It's possible we're going to win the Powerball. I'm going to buy a villa in Italy and you won't see me on next year's broadcast. Is it probable? No, right? So again, it's always hard when you say possible to a doctor, the answer is always going to be yes. Is it probable? That's the question you want to ask. And then the other thing is informed consent. You have to give consent. Patients and their families have to give consent that we talk about the trial with you and we spend some time. So we're not ever trying to pressure you and, hey, you got to do this clinical trial. We're like, hey, you might fit. Let's sit around and talk about it. Here's some of your responsibilities. Here's some of our responsibilities. Here are the costs. Here's what the visits entail. And here's what we think are the potential benefits for you. So we really, really believe highly in clinical trials. It's really important. So ask questions, right? I mentioned earlier, shared decision-making. You have to talk to the doctor about, hey, what's the purpose of this trial? What are the benefits to me? What are my risks, right? Risk-benefit ratio. People are like, I read the risk of this, drug, and I don't know if I want to do that. I'm like, well, okay, well, let's talk about risk benefits. Do you ever read a risk of what happens when you drive your car? The bad things can happen. Those probabilities are low. So again, risk-benefit ratio always fits in. Why are you recommending this for me? What are the treatments available? What organization sponsors it? Who's reviewed it? Does this trial include the use of a placebo? How do I know if I receive one? These are all really good questions. A lot of these trials are double-blinded, placebo-controlled. So I don't know if you're getting the real drug, and you don't know you're getting the real drug because there can be some biases in there that can affect the outcomes. How do I know if I qualify? The clinical team helps that with research. And then do I have to pay to participate? You never have to pay to participate. You may receive some compensation from the clinical trial. All right, so we've got some clinical trials in prostate cancer right now. One of them is called Libertas. It's really to determine if intermittent use of ADT or hormonal therapy in those patients with metastatic castration-sensitive prostate cancer. So disease has already spread to other parts of their body, but they're still sensitive to hormones. And you get a PSA lower than 2 after 6 months. Do they still need it? What's the radiographic progression-free survival? Is there a reduced burden of hot flashes after 18 months? So it's a way to kind of see if we can minimize some of the side effects, but still maintain the same rate of cure. The other thing is Vapor 2. And again, this is a water ablation device treatment for focal prostate cancer. So I mentioned earlier, focal therapy. So this is our trial for that. I think this is going to be a great treatment someday. The inclusion criteria is really narrow. So a lot of guys are like, hey, I really want to do this. I'm like, you don't qualify yet. But if you're on active surveillance for a while, maybe you will qualify. But that's going to be I really like that trial. So you can talk to clinical research department at any time. Danielle Osterhout is amazing. She runs research and she is fantastic. So it's 248-786-0467 or research@michiganurology.com. We have a lot of cool things and Danielle's awesome who runs it. Okay, this probably gets to the point of you might have a couple questions and I'm happy to answer some of those questions in the chat box. I think I got Steve on his HIFU. I do, there was a question about someone's MRI and their lesions and things like that. Again, I can't tell you what to do, but I can touch base on what that means. So on an MRI, we see some lesions and they're called PIRADS or PRADS lesions. And most of the loose lesions, if they're a 1 or a 2, are completely benign. If they're a 3, they have maybe a 15 to 20% prostate cancer risk. If it's a 4, you jump to about a 30 to 40% prostate cancer risk. If it's a 5, it jumps to about 70. So we technically normally say, hey, if you have a PIRADS 4 or 5, you definitively need a biopsy. And 3s, we kind of use our clinical judgment whether you need a biopsy or not. David, let's see, precision geogenetic testing. That's a really good question. So David asked, is it only used after a prostate cancer diagnosis, or can it be done proactively for patients with moderately high PSA? So again, I think, like, I saw a patient in clinic today who has already been tested because his dad and his brother have already been diagnosed with prostate cancer, and he came out with a BRCA2 defect. So he's got a little bit higher PSA than normal. And now that I know he's got a genetic defect, I said, look, you need an MRI and we're doing a biopsy because you're at such a high risk. So we use it as more information to make clinical decisions. So there are very few black and white decisions that we make, but again, if genetic testing is really helping us. Low T, does that suggest a lower risk of prostate cancer? Not really. We still see people with low T levels and they have prostate cancer and high T levels. It may affect it a little bit, but it's not a black and white issue. Ayad said, how do I qualify for the vapor study? Well, I'm assuming the vapor study and not the Libertas study. So you have to call the research line and they'll help you. Primarily, you need to have low grade prostate cancer, Gleason 4+3, confined, and there's some other specific parameters in there. Yes, John, we get bombarded with ads for various prostate non-prescription drugs. Are they actually helpful? Okay, so snake oil existed a long time ago. Snake oil still exists today. So if you look at, and this is why I mentioned double-blind placebo-controlled studies. If I give you a placebo and you don't know it's a placebo and I say it's going to help your prostate feel better, 40% of people feel better because we told them they're going to feel better. So you may just feel better because you're taking the drug and you want to feel better. There's some clinical data that suggests anything with saw palmetto may be helpful. So I would rather, and they're always expensive, right? Nobody ever gives this stuff away. And you sign up for it and then you can't cancel and it's piling up at your house. So I would say before you just jump into some over-the-counter, health brand that's Prostate Beta, whatever, that's going to be Zoom and helping you, I would go talk to a urologist about it first and save your money. Comparison of HIFU to remove your prostate, radiation for stage 1, Gleason moderate aggressiveness. Steve, I'm going to tell you the same thing I tell everybody. How do you want to go to Chicago? Drive, fly, take the train, ride the bus. Radiation, surgery, HIFU, cryo, HDR, nanoknife. There's some risks and benefits to all that, and it's a much longer discussion than what you and I are going to have over the web here. I do like HIFU. I also don't like HIFU. Like, I like surgery and I don't like surgery. So it's out there. I will tell you that one of the biggest problems we've had with HIFU is getting it paid. And so there's been some issues with that. So there is a potential financial toxicity to HIFU that I'm not a big fan of. Let's see, my PSA went from 8-ish to 15 to 8 on the last 2 tests. Seems like a lot. Do we need to talk soon? Dale, yes, we need to talk in July. But again, we'll have to talk about why it went up. Did you have infection? Did you have COVID? Were you on steroids? There's a lot of reasons. Were you riding a bike the day before? Were you having sexual activity? So again, the trend is important, but again, we'll have to repeat it and potentially do an MRI. Frank asked a question about saturation biopsy, 36 samples instead of 12. So before we had MRIs, we had a very small window that we started doing a lot of saturation biopsies because we felt we were really missing things. I'm not so sure that we're missing a lot of things now with PSA, or I'm sorry, with MRIs, 3D MRIs, so appropriate MRIs. So I think our saturation biopsy went down. We do targeted or focal MRI fusion biopsies. So we're kind of layering the MRI with the biopsy. So we're making sure we're targeting that. So I think the days of saturation biopsies are kind of going away, which is good because a lot of those saturation biopsies, guys would have significant discomfort and they wound up having a catheter and retention. So I think saturation biopsies are kind of going away. SBRT version of high dose brachytherapy is one treatment for Gleason 3+3. So again, I think a lot of Gleason 3+3 can be watched. So again, that's my bias about that. X-ray, so external beam versus HDR, driving versus flying, right? So if you live around the corner from the radiation center and you want to go 5 minutes a day for 6 weeks and go play golf every day, I think that's great. If you live up in Alpena and you want to drive down every day, that doesn't make much sense, and HDR may be a better fit for you. So again, one is outside in, one is inside out, risks and benefits of both. Gleason score, yes. Okay, so we look at a pattern, right? So I have this pattern on my tie. And if my tie was polka dot instead of stripes, I'd say, hey, these polka dots over here look a little bit funny, and this polka dot looks a little bit worse. So this may be Gleason 3, and this may be 4 because it looks worse. So we would add 3 plus 4, and that would be a score of 7. If we had a lot of 4 and a little bit of 3, it would be 4 plus 3. If we had no 3, it would be 4 plus 4. And the higher the Gleason score, the more aggressive it is. So it really starts at 6 and it goes to 10. If you have androgen deprivation therapy and you complete it, will the symptoms of this therapy subside? Yes. So eventually. So when we give someone hormonal therapy, we normally administer it as a shot. It used to be castration, right? We used to do an orchiectomy. And then medicine got better. We don't do that anymore. And now we give you a shot that can last for 3 months or 6 months or a year. Eventually, when that shot wears off, your testosterone should slowly come back to life. Now, there is a new oral drug called Orgovix that is just as good at lowering your testosterone. But one of the benefits of that drug is when you're done, if you're only going to be on it for 6 to 12 months or 2 years, when you come off it, it tends to respond and your testosterone goes up better. So we're using a lot more of this new drug called Orgovix for that region. Decipher. What's a Decipher score? Frank, good question. So when we look at a prostate biopsy under the microscope and we give it a Gleason score, there can still be some gray areas because it's pattern recognition. So you might see my tie and go, I hate that stripe. I think this part of the stripe looks worse. And someone else says, I like that part of the stripe better. So there's some subjectivity to it. A Decipher score or a Polaris score can actually extract some DNA and some tissue out of the biopsy and predict is, hey, this Gleason 7 score might be a little bit more aggressive than we think, or more or less aggressive. And there's also another one called oncotype. So we would run that in some of those people. And so some of those people, we may say, hey, look, you don't necessarily have to do anything, or this Decipher score or Polaris score or oncotype score is higher. We may want to do something. So it just gives us a little bit more information. Frank's been doing his homework. He's on Dr. Google. When dutasteride and tamsulosin are intended to address BPH symptoms, do you think their reduction impact on bad testosterone should help address prostate cancer? Okay, so we know, so there's 2 types of medicine to help you pee better, right? So one is alpha blockers, Flomax, tamsulosin, alfuzosin, uroxetrol, and Rapaflo. They basically work by relaxing the donut and opening up the donut hole so you can pee better. Medicines like dutasteride or finasteride work long-term by shrinking down your prostate. There's some data suggest that if you have low-grade prostate cancer and you're on active surveillance, or you don't have prostate cancer, but you have a high risk of prostate cancer, if you're on these medications, it may lower your risk of progression. So I personally believe that. The problem is I'll put people on finasteride or dutasteride and they read somewhere, because you can read everything out there, that it's actually can increase your risk of high-grade prostate cancer. And then patients come in and go, Doc, I read on the internet and you're wrong. It's going to increase my risk of prostate cancer. You're trying to give me bad prostate cancer. I'm like, yeah, that's what we're trying to do. No, it's not what we're trying to do. But much like when someone gets arrested and there's a big splash on TV and then the next day they find him not guilty, it's never on the TV. There were some studies that found out that if you're on finasteride or dutasteride, it actually shrinks down the benign tissue. So if you had some high-grade bad prostate cancer that was floating around in there, now we can actually find it easier. So it's actually an advantage, not a disadvantage. But that long spiel never makes it on Google or all the internet and all that stuff. But so yes, I like dutasteride or finasteride to lower your risk of developing prostate cancer. And actually, if you have on active surveillance, it may lower your risk of progression. Any diet to prevent prostate cancer. So heart healthy is going to be prostate healthy, right? So exercise is going to be prostate cancer healthy. So any diet that's relatively low in red meats and high in polyphenols and fruits and vegetables are going to lower your risk. If you look at people who live in the blue zones around the world, people who traditionally live to be 100, right? So they're eating not a lot of processed foods. They eat little meat. They eat some fish. They eat a lot of vegetables. They eat a lot of legumes. So I think that probably helps you. Again, polyphenols are great. So red wine, not white wine, has polyphenols. So that's my excuse for red wine. So again, I think it's a component to it, but I don't think it can completely prevent it. Low, high, medium Decipher score, right? So if you have a high Decipher score, you may need combination therapy. If you have intermediate prostate Decipher score, you may just need single treatment. If you have low Decipher score, you may be able to just watch it. What causes your PSA to decrease? So again, if you have inflammation and your inflammation goes away, your PSA may decrease. Medicines like dutasteride or finasteride can help it decrease. Really, the question is, what makes it increase? So there's a lot of false positives, right? You know, COVID increased your prostate cancer. Vaccines increased I'm sorry, not your prostate cancer. Don't quote me on that. That was a slip of the tongue. COVID can increase your PSA. The vaccines we found could increase your PSA temporarily. Infection, inflammation, sexual activity, bike riding while having sexual activity, being constipated, all those things can increase your PSA. So sometimes when people see me and they have an elevated PSA, one of the first things I do is say, hey, look, we're going to get your PSA in a couple of weeks, avoid sexual activity, avoid bike riding. We'll just see what for 48 hours ahead of time, and we'll see what that is. So again, there's a lot of false positives to PSA. If you get on Flomax, you have to stay on it for life, probably, because you're just going to relax that donut hole. And when you stop taking Flomax, the donut hole gets constricted again. David, do the meds you mentioned have side effects? So yes, so dutasteride and finasteride in about 5 to 10% of men can have some sexual side effects. So loss of libido and some mild erectile dysfunction. So when I say 5 or 10%, every patient hears 100%, but it's only 5 or 10%. And if you take it for a while and you develop those, you can stop the medicines and it comes back. Phone number for clinical trials. We had it up there. Let me see if I can get back to it. Phone number is 248-786-0467. Oh, look at our great tech team putting that back up there. Thank you, guys. That's awesome. I had it on the side, by the way, but that's good. All right, I think we're winding down. We have a few more minutes, so any earth-shattering questions? Danielle Osterhout would be our head of research for clinical trials. All right, we've wound down. Everybody's bored. We've answered all the questions. So my takeaway message is, number one, please, 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 any man you know, or if you're a man out there listening, get a PSA once a year. Know that if it goes up by more than 1 point in 1 year, that's a problem. You need to get it repeated. And then if it's still high, go see a urologist. That's take home message number one. Number two, if you know anybody or you get diagnosed with prostate cancer, go tell everybody to get screened. Don't be embarrassed. You had nothing to do with it. It just happens to people, right? But when you don't tell people about it, that's how people die. I see 2 to 3 guys a week in my office coming in with PSAs of 500 or 1,000, and it's crazy. And those guys, we're going to struggle to keep those guys alive. Now, again, we got new medicines, but that should never happen. So please, 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 I'm begging you, get screened, get a PSA once a year. If it goes up by more than 1 point, come see a urologist. Jim, did I get this question? I got the question of, Jim, did you get this question? But I don't know what your other question was, Jim. So if you're still out there, ask it again. We'll stay on for a minute. They were coming in like wildfire, so I probably missed yours, Jim. Peter, look at Peter with the big brain. How common is the Hox B13 defect? Pretty rare. Yeah, I think we've only seen a couple patients with it. But again, part of it is we're 2 years ago, we weren't testing a lot. So we're starting to test more. So if you come in with metastatic prostate cancer, we're testing now for all these genetic defects, and we're now testing more and more and more, but it's pretty rare. All right. Listen, this was fantastic. I guess we'll give it 6:21. And I think we're going to land the plane. We'll give you guys about 9 minutes back in your life. Thank you very much. If you have any questions, you got research trial questions, talk to Danielle. If you have any other questions about urology, MIU's got, I probably have 40 or 45 partners. We have so many I don't know, I'm not sure I know all their names, but they're all fantastic. So go see them. TNM grading, Peter, is there a grade M for positive margin after surgery? No, that M is 0. That's it talks about T3A or B, meaning outside the prostate. If I choose radiation therapy and years down the road, cancer comes back, can you do the surgery? William, you saved us. We're going to land the plane on this question. This is a great question. I'm so bad for not answering this question earlier. So one of the people they have their anxiety of like, oh my God, I've got prostate cancer. You're telling me I have a 90% cure rate if I do radiation, surgery, cryotherapy, HIFU, HDR, whatever. How do I pick? You pick what makes you happy, and you sleep at night, and we pick this as a team. If you're in the 10%, right? So let's say you had surgery and 10% of those patients have a recurrence. Okay, they go get radiation therapy. That's easy. If they had radiation first, and again, 90% of you will be cured, what happens next if you're in that 10%? If you're young enough, because we have robotic surgery, we can still do robotic surgery on you. However, technology is better. So now we're using focal therapy. We're using HIFU. We're using cryotherapy. We're using nanoknife. We're going to probably someday use vapor. So we'll be able to treat it no matter what with lower side effect profiles. So I wouldn't worry about what might happen 10 years down the road. I would pick what's going to happen now and what's going to get your best outcomes with the risks and benefits that you can deal with. And then we'll see what happens in 10 years. Listen, in 10 years, there might be a magic bullet and I'll be out of business and I'll be, making pizzas at the local pizzeria. So we'll see what happens. All right. I want to thank everybody for being around. You guys were great. You had great questions. And I'm really, really happy to be here and a part of this discussion. So everybody have a great summer. Get your PSA. Know what your PSA is. More than 1 point in 1 year is a problem. All right. I'm landing the plane, guys. Thank you very much. Peace.